You know, one of the reasons that I love what I do is because I get to be part of innovative solutions. And I'm proud to say that my Army is an innovative organization. And so I think that's critically important. What you're going to hear from our next panel is how some of this innovation in mental health treatment can improve physical well-being as well. So our moderator today, United States Navy Corps Lieutenant Commander Dr. Kimberly Albro. He is an expert in assessing the treatment of post-traumatic stress disorder. Directly across from him is Dr. David Krause. David's the President and Chief Scientific Officer of Outcomes Referrals. He's a preeminent scholar on behavioral health assessments, and he's been awarded 2 U.S. patents.
Thanks, Lou. There's been a lot of attention paid to improving how communities approach mental health care, including better understanding the root causes associated with trauma and improving how we connect people with the right kind of care. Could each of you share your work in mental health? Brian, we'll start with you.
Well, first of all, thanks for having me here, government. But I am a clinical psychologist. I work at VA Boston Healthcare System. I'm also a researcher at the National Center for PTSD, which is a multi-site consortium. And we do a lot of different work from bench to bedside, so to say, with respect to understanding the causes of PTSD and developing various treatments for it for the purposes of helping our veterans who are served by VA.
David, I'd like to hear from you.
Sure. I'm David Krause. I'm a clinical psychologist. More than 30 years ago, I was working as a assistant professor of child psychiatry at UMass Medical School, working with the most traumatized children in Massachusetts. Since then, with funding from the National Institutes of Health, the Patient-Centered Outcome Research Institute, and foundations like the Duke Endowment and the Annie Casey Foundation, we've created targeted treatment testing for behavioral health. We can predict who will benefit from care. We can predict where they will most likely benefit the most. For example, a partial hospitalization program versus an inpatient program. And also from whom will they benefit the most from. And that's what I'm delighted to share with you more today, which is that virtually every clinician like myself has areas where they are exceptional and deliver reliable outcomes that are well above kind of national averages, and also areas where we're reliably harmful. So for example, for myself, I'm reliably harmful at treating substance abuse. I'm very good at treating complex trauma. And if we figure out how to deploy those, we can get remarkably better outcomes for a population.
It's like precision medicine for therapy and
Exactly.
mental health. That's great. Good to hear from each of you as well about what do you see as needing to change in the overall approach, leveraging innovation, using new techniques, methods, and technology to really improve how we're able to deliver healthcare to veterans. David, I'll start with you.
Sure, I can think of a lot of things that need to change, but I think the highest thing I would put at the list is understanding that behavioral health is powerful and can be harmful. And in the wrong hands with the wrong person, like for example, if you hand me a substance abuse client or a family that has a propensity for substance abuse, it's not going to be a good outcome no matter how well-intentioned I am. We think that talking, it's a talk therapy, how can that be harmful? And I think that devalues the service that we're delivering. It is powerful, the data shows that it can be powerful, but at the same time, it can be harmful in the same way that parents can be harmful to their kids with physical and verbal abuse. And so that we need to be mindful, and every one of us as a clinician, instead of guessing what we think we're good at, we need to use data to prove it. Because our research shows that the correlation between what we think we're good at and what we're actually good at is so poor it's not useful in making assignments of who should see whom. And so it really needs to be data driven.
And how does that translate? How do we keep people from claiming to have a skill set that the data has shown them not to have, to say that they're good at substance use disorder treatment?
So for example, in the randomized clinical trial that JAMA just published this last year, we went to the Cleveland Clinic. We went to their primary referral pathway out into the community, and we transformed it almost overnight into something that was, hey, I'm a clinician, I think I'm great at treating depression, give me depressed patients. That was the control group. And those patients ended care on average debilitated. A little bit improved, but still clinically with lots of problems. Doing it empirically, we were able to have the average patient end care healthier than the general population and maintain those gains for more than a year. And so that data fed back to primary care, fed back to the clinicians. The exit interviews from patients and the clinicians themselves was, why wouldn't I want this to be data-driven?
Yeah. And I can tell you as a family nurse practitioner, that would be invaluable to me to know that, to have an idea of what a patient needs and be able to send them to a mental health provider who will really help them along their journey of healing and recovery.
Exactly, and just real quick to add to that, if I'm a small group of clinicians and the four of us are figuring out who should see whom, of course I want Renata to see the patients who I'm not great at treating and vice versa. It's a win-win for both the clinician and the patient.
Problem, and we refer to someone else.
It's great to hear the thought process being take care of your brain, your mental health, your well-being the same way you take care of your body and your physical health and well-being. A really important point that I know is becoming increasingly the narrative. Brian, can you tell us a little bit about your work in the VA?
Yeah, absolutely. We have done a lot of work in the development of new treatments for PTSD and other disorders that are related to trauma exposure. We recently just completed the largest randomized controlled trial of the two gold standard psychotherapies for PTSD, cognitive processing therapy and prolonged exposure, to compare with one another, to see which of these two treatments might be better or are they equivalent and whatnot. Essentially, we found that they did fairly similar in terms of the veterans that were randomly assigned to each condition, but we're right now in the process of looking at the predictors of treatment outcome for these two particular treatments. And I was glad to hear you bring up that different therapists are good at different things. I think that that's a really important point. When we see a treatment failure, what we tend to immediately assume is that it's the fault of the patient or it's something along those lines that we already have available.
Can I just piggyback
Yeah,
on that?
please.
Because outside of the VA, multiple studies have shown that only about 40% of patients benefit meaningfully from behavioral health. And that's because of this mismatch issue that Dr. Marks is talking about. And so if we can figure out how to solve the problems that he's addressing, that number can probably be upwards of 90%.
And what I'll say to that is that in this study, even though we did find that many patients did improve in both of these treatment conditions, roughly half of the veterans who were in the study still had PTSD by the end, right? And so it works, these treatments do work, but they don't work the same for everyone. And so we need to do a better job of understanding why that is and how do we augment these treatments in order to have them work better for those who receive them.
That brings back to the point of being data-driven, because like you said, you can have temporal improvements, but sometimes we live in a society that if someone has post-traumatic stress disorder, clinical depression, et cetera, there is this expectation that I go to treatment and he gets removed. It may be that you are going to have a continuum of difficulties.
That's right.
Sometimes better or worse, and even when one of the diagnoses may be discharged from that diagnosis, something else will come along because life happens. And it's not necessarily just because you've seen combat. It can be anything, really. And actually, as a nurse, you probably understand this better than anyone. one of the main causes of significant psychological trauma, at least in Europe, tends to be childbirth. So, with all of this, and you need the data, the constant referrals, and this, inter and multidisciplinary approach. I would say a few years back, you probably wouldn't see people like ourselves in a panel together, and now we heavily rely on each other. Is a top, bottom, and side, whatever approach you want to have, and yes, and the data is quite important. It's not that numbers are everything, but they are quite something.
Yes.
Yeah. And I think as more veterans are seeking care potentially outside of the VA, it's essential that those civilian therapists like myself understand the unique differences that those that are veterans, first responders that are dealing with, for example, having to put on that mental body armor is very different than many other walks of life and folks. I think those of us that deal with childhood trauma are good at helping people take off that body armor, not good at figuring out how to put it back on and understanding the value of that.
And Renata, you bring up childbirth. I have 4 little ones myself, and I just remember preparing to give birth for a 3rd and 4th time and saying to my OB provider, I had a hard time after my last child was born. I would like to talk to someone, and I would talk to someone who was ready to help me to manage postpartum anxiety and postpartum depression, but was a little overwhelmed by the fact that part of what I'm worried about is that I've seen really bad things happen to really small people in combat. And I think that shock that I caused in my mental health provider, I drew back and decided I was a bit too much for this person and didn't continue with some of the talk therapy that might have been helpful. And I think that awareness, and even in places like obstetrics, you wouldn't necessarily think about needing to deal with combat stress as a precursor to what might become, a condition following childbirth.
Yeah, I think these are all really important points, and what you're saying here reminds me of, I think there's something really important that I think we're all touching upon here is when it comes to dealing with trauma and its aftermath in therapy, not only can that be challenging for the patient, but it's also oftentimes very challenging for the healthcare provider, especially those who are not trained and don't have a lot of experience doing so. It causes a lot of anxiety, a lot of reluctance, a lot of concern that if I bring this up, if I talk about it, then it's going to upset the patient, and how am I going to deal with that? And I don't want to have a patient in my office who's crying and really distressed, and maybe I cause a suicidal crisis here, and so on and so forth. But the fact of the matter is that we know that these treatments that work best for dealing with the after effects of trauma actually, the whole point is to actually confront the trauma head on, which is easier said than done, certainly. But we know that that's really what needs to happen.
And if your provider is afraid of what you want to disclose,
Correct.
To me, from my standpoint, thinking of harm, that's how subtle harm starts. And if that wedge divides, and that's why you're there and what you want to talk about, and your provider can't handle it, well, then what's therapy for?
And I remember being asked, have you been to the VA? And I live in Central Virginia, and the closest VA at the time, we have a clinic there now, but was in Richmond. And I was like, no, I have a full-time job and 2 other kids. I'm here now.
So I think that brings another point with the experience you shared of how, possibly combat trauma rehabilitation or support would have been quite useful, but you weren't in a combat situation, but however it was quite traumatic, childbirth. And you touched a lot on these points about the different backgrounds, and it makes me think about the cultural differences, which makes the matching even more important. I mean, yes, I'm an ethnic minority British female, but I come from Britain, where we have the I don't know if it's fortunate or unfortunate, stiff upper lip, right? And that itself, just understanding that that's our baseline of the smile and wave, and I feel sorry for the clinical psychologists that need to get through us. So that's just understanding, a little bit like we were talking about removing the body armor from the children, but then that body armor needs to go back on, and it's not easy, is it?
Right, especially if they're going back to a family where a trauma might be continuing.
Correct.
Right, and we've learned that certain therapies that we thought were wonderful, like critical incidents debriefing after a plane crash, are reliably harmful and shouldn't be done, because we're asking people to take off that body armor the second after a trauma, which is just a disaster.
Right. We do have a VA healthcare system in this country. What you're describing is still very similar in the sense that there are services in the military that try to assist the transition from military to civilian life. We know that that transitory period is very challenging and potentially risky for service members, but not everyone who makes that transition actually finds their way to the VA. And what you described in terms of your experience is a lot of what we see, where folks have come in, they have put things away, they haven't thought about it, they haven't, in a long time, they haven't talked about their experiences with anyone, and they're afraid about what might happen when they finally let go and start that process. And it's very, very scary for people, and we get that, we understand. Fortunately, I feel, like I'm in a good place where people are generally trained well to deal with that and help veterans to begin that process of healing. Although, again, there are challenges for lots of different folks along that continuum of care. Outside of VA, it can be, I think, even more of variable in terms of the care that folks receive and their understanding of what might be needed, and the reticence they might have about, sitting with someone as they're opening up for the very first time and talking, frankly, about really, really tough things.
What you just described about the heterogeneous nature of providing care within the VA, I think we would like, obviously, the care to be quite homogeneous in terms of its level of excellence. And of course, we do understand there will be centers of excellence for A, B, and C, subspecialties, etc. But still, we're trying to be homogeneous in the level and standard of care, to understand that every veteran, every Marine, every family is heterogeneous. And going back to your personalized and specialized, individualized approach to one's well-being and care, it's not easy, I know, right?
No, I keep going.
So it's just, I don't know what the answer is, but homogeneous in terms of standards of care, understanding that sometimes you may have to go to Boston for combat trauma, but understanding that Kimberly's family is, there is no twin family to that, and then there is your community as well. So it's holistic, right?
Yeah, I mean, from my perspective, diversity is wonderful because it's an opportunity to learn. So if we were all standardized on one thing, the ability to improve on that is more difficult. The learning across the pond of how we're different, tying this to the first panel around disclosure, there are times where the way I can relate to it is I'm a pilot. You cannot hold a medical and have a behavioral health issue. And so, for example, for my uncle, who was a pilot for TWA, his depression had to go untreated, which is the exact opposite thing you want to have potentially a depressed suicidal pilot flying you commercial somewhere. right? It's just not the right thing to do. And so what the FAA has done is in some ways done exactly what possibly the military has done, of disclosure possibly makes it harder to be ready to put on that body armor and be ready for combat. And it's possible that across the pond there are different ways that we're handling things. The Boston VA probably is the pinnacle in the VA for many different things, but there also may be things that we can learn from someone doing something unique. So to tie that back to the child side, for example, we found the clinic in the United States just on data that was treating child ADHD the best. It was an outward bound kind of program combined with therapy in upstate Plattsburgh, New York, middle of nowhere. Right? Those are the things that we're proud of finding. And they had no idea that they were 3 times more effective than almost any other treatment of ADHD in the country. Right? Those are the things that we're proud to go out with data and go find and learn together with that diversity. So diversity I see as a great opportunity to learn.
Right?
And we can learn from the private sector and work that's being done in private clinical practice as well. I have asked all the questions here, and I'd like to open it up if there are any questions from the audience for the panel. Please feel free to stand up and ask your question.
Hi. You've each presented different approaches to healthcare, 3 approaches from 2 different countries. I know you've kind of covered it a little bit, but how do you see elements of each of these being combined to improve veterans' healthcare, both in the US and possibly back in the UK? Thank you.
I can start. I actually see our 3 approaches working really well together. So for example, creating new, wonderful, evidence-based treatments. We know that there will be some therapists that are much better at delivering that than others. And so that fits well with finding the right therapist for the job. And we also have found that there are, beyond just the clinical domains, like who's good at treating substance abuse, who's good at treating depression, we've also found that there are different demographic groups that therapists are best at helping. And that includes minority groups versus just a Caucasian population. It includes people with different medical problems. It includes people that are LGBTQ. And so I think finding clinicians, for example, that are really good at helping wounded warriors, we can identify them in the same way, matching basically at 2 important levels. One is who understands and has the sensitivity, and I think your description that you shared is a perfect one that helps us hold it in our heart, what we're looking for in terms of who will likely be really good, who is not so blown away, for lack of a better word, by what is being disclosed that I don't know how to handle it. So anyway, I think there are great ways to blend all of the things that we're innovating.
I think from my perspective, it's not about the different things we're doing, is how we connect them and sustain it. Because at least from our institutional perspective in terms of Bravo Victor and others, is you will see that we work, everyone is an equal partner, from for-profit, not-for-profit, government, and so on. And it is about achieving the outcome.
Trying to figure out how to solve really, really hard problems. And I think that is, when it comes to figuring out how to end the, suicide epidemic among service members and veterans, or, how to best, get people the treatment that they need, or how to facilitate access to mental health care to rural areas, things of that nature. You really need people who bring different things to the table to really solve the problem.
Absolutely, and to learn from other countries and other places that have done it differently, done it well,
Right.
done some aspects better than we do here, and can share and learn, and we can all be united in that experience. Well, I have great hope as a veteran for the future of healthcare for veterans, both in the VA and outside of the VA. And I thank you so much for your time here to chat with us about your experience, and I hope we have a chance to work on this going forward.
Thank you.
Thank you.
Thank you to all our panelists.